So the instructions that you'll receive for your long cases, this is a 90-minute session. You'll hear about 8 minutes and again after 11. Ignore them. This consultation will be conducted as if it were one or more appointments. You will generally be told. Read the following scenario, take an appropriate history from a patient. When you are ready, request the details and appropriate physical examination from the observing examiner. Outline your diagnostic impressions and advise the patient. If further investigations are necessary, outline your conclusions and your proposed management to the patient, and manage any significant elements of the case. Okay, additional instructions that again could be there is take an appropriate history from the patient, conduct an appropriate physical examination. You may or may not have to do that, and tell the observing examiner your findings as you go. Remember to include all positive and negative findings. Talk your way through it. Tell the observing examiner your differential diagnosis. If you are considering diagnosis that you do not wish to discuss with the patient at this time, you should inform the observing examiner of these diagnoses. Outline your diagnostic impressions and advise the patient if they need further investigations. Request any results of investigations and outline your conclusions and your proposed management plan. Okay, so the scenario that you get given is that you've got a 2-month-old boy who's been brought in by his mother. She is concerned about his rash, and he has had the rash for a few weeks and it's getting worse. So Samuel, as we said, is 2 months old. He's got no allergies, lives with his mother. Mother had asthma as a child. Father's history is not known. Immunisations are up to date. Born at full term by caesarean section and is breastfed. Okay. So you need to make a note of the key features of the case. Write down things in the history that are missing. For example, does the mother smoke? Write down the most likely causes of a rash in a 2-month-old and what must not be missed. So you're thinking meningitis. What else would you like to know? Is the child sick or well? Further history of a rash. I use Nil de Calf to help lead some of my questions on pain, but also I use them for other things like rash. So nature, intensity, location, duration, onset, offset, aggravating, relieving factors, character, radiation and frequency. Be confident. This is what you do every day. Relax. This is just another day in the office. Okay. Now, this is the information that's given to the role player or the examiner. Information that is freely given to the candidate is that Sam is getting more irritable and it's starting to affect his sleep. He's also starting to fuss when he's breastfed. Prior to the last 2 weeks, he was a happy, healthy baby. He was born by emergency caesarean section for failure to progress. He's otherwise well after birth and went home on day 3. Mum has never seen a rash like this before. He hasn't been otherwise unwell. He's got no cough, no vomiting, no diarrhoea. So you need to figure out what else do you need to know. Okay, there's information that the examiner or the patient has that will only be given when you ask the appropriate question. So he's felt a bit hot, but Mum doesn't have a thermometer. The rash is generalised: face, head, chest, back, belly, arms and legs. There is no rash in the napkin area. The rash seems a bit different in different areas. Some of the rash looks scaly, some of it looks like pimples. Most of it looks red and the redness is getting worse. It looks itchy and she thinks she has seen Sam try and scratch it. Settles when cuddled, though it does take a few minutes. Settles better if he's swaddled. The mother has another 6-year-old son who doesn't live with her, who also has asthma and eczema. All this whinging and crying and lack of sleep is also getting to Mum. She wants to help him but doesn't know how. She's worried that Sam isn't feeding as much as normal and his nappies are more dry than normal. She recently bought a different laundry detergent as it was on sale. She usually buys the cheaper soap flakes. They've moved house and it has mould and carpet. previously tried Sorboline, and that did seem to work, but it's not working anymore. There are some of the examination, if you just say, can I have the results for the examination, physical examination, they may give you a sheet, they may not. They may just say, what would you like to know? Sometimes if they give you a sheet, just remember it may not be everything that they're able to give you. So make a mental note, okay, what else might I want to know? The general appearance is generally unhappy, irritable, crying and not settled. He's pink and well perfused and still making tears. Slightly tachycardic at 160, and he does have a temperature. His respiratory rate is 30. His weight is 4.3 kilograms. Heart sounds due with nil. Chest is clear. Abdo soft and non-tender. Nervous system is alert, active, grossly toned and pale and normal. Gaz, you might be doing the live case with me. Okay, skin. He has significant cradle cut, blanching red rash across his whole body that is mostly dry, but does have pustules scattered over his body. There is no rash in the nappy area. The rash is obviously red and angry. Sam seems to try and scratch the rash, and there is obvious excoriation with small spots of bleeding. Okay, so what's your provisional diagnosis? From your provisional diagnosis, what do you need to do now? So your provisional diagnosis is, obviously eczema. But what else is your provisional diagnosis? So you've got to think he's got a temp of 38. So is he septic? Does he have, impetigo, so staph-infected eczema? Could it be varicella-infected eczema? So what you do now, you really have to summarise, and sometimes you need to stop for a couple of seconds in the case and go, okay, what are my main points? Your main points are going to be you've got a 2-month-old with a rash, a fever, decreased feeding, mum's not coping. That should tend to point you to where you should be going. So what are you going to do? Okay, so this is a second consultation. Hopefully you said he needs to go to hospital. Any child basically under, let me just think about this. Any child under 3 months of age who has a temperature over 37.9 needs to go to hospital. And any child under 3 years of age with the temperature over 39 with no clear cause needs to go to hospital. Even if you've got a clear cause in the 3-month-old or less, with the temperature of 37.9 or above, they still need to go to hospital because of the risk of occult sepsis. So, Sam and his mother return after his admission to hospital. Whilst there, Sam was treated with intravenous antibiotics and wet wraps, and he was discharged with oral antibiotics. Information that can be freely given at this point is he's much happier, but he's still bothered by the rash and it still affects his sleep. She's still finding it hard as she hasn't had time to catch up on sleep as she didn't get much in hospital. She still doesn't quite know how to manage his eczema as the hospital only taught her about wet wraps and that only involved showing them to her once and then expecting her to do them. Okay, information that's given if asked. So mum has the 6-year-old who doesn't live with her, who has eczema and asthma. He lives with his father as she has a history of drug misuse. She hasn't used it in 2 years. Mum is taking walks around the house just to try and escape the crying as she finds herself yelling at Sam. She has no suicidal or homicidal thoughts, but she does want to escape. She feels useless with regard to his eczema. She still doesn't know anyone in the area. She recently bought a more expensive detergent as it was on sale. Mum smokes. The house they moved into has mould and carpet. She washes Sam daily with a well-known baby wash. So you need to talk about what your management plan is from here. So what issues actually need to be covered. So you need to cover, does she have postnatal depression? If so, does that need to be treated? Oh, can you go back? Oh, okay. Yep, I'll go with this. So you need to, yeah, thanks. So you need to go through, and also psychology if that's going to help. You need to go through how you're going to treat your eczema. Actually, yeah, can I go to the next slide? Sorry, Jazz. Okay, so you need to discuss eczema, causes, management, and natural history. I usually give the patient or the mother some written information on this. So you'll need to identify potential allergens and irritants, like the detergent, and how to minimise exposure to them. You need to talk about how to prevent eczema flare-ups. So the things you need to include would be avoid baths. So it doesn't need to get bathed every day. Every second day is fine. Bathing without soap and just pat dry instead of rubbing dry. Use regular emollients. The cheap unscented Sorbeline is best, or Dermes. Cotton clothing. The soap flakes that Mum was initially using is perfect. Mattress protector to decrease the exposure to dust marks. No smoking. Get rid of the mould. Keep the carpet clean. Put cotton sheets down on the carpet so that he can play on them. Reduce scratching by putting gloves on the baby. You discuss steroid cream and ointment and its use. When he's a bit older, you'll need to discuss about how to start solids, given the fact that he's got severe eczema. Also, because he's got severe eczema, you'll need to talk about, does he need allergy referral? Sam is at increased risk of not growing out of his eczema because he had severe eczema from such a young age, and there is a strong family history.